Hi, everyone. Thanks for joining. I'm just going to give one moment to allow everyone to make it into the room today. We have a really wonderful attendance, Carolyn.
I see. Yeah.
Might be a recent record.
No pressure, right?
Right. Exactly. All right. It looks like we have a critical mass. Well, thanks for joining us, everyone. Hello, my name is Becky Wolfkiel, and I'm the Executive Director of NASHIA. Thank you so much for joining us today for our webinar with Dr. Carolyn Lemsky, Tools for Your Trade, Brain Injury and Behavioral Health. Next slide, please. Thank you. I'm joined today by our Director of Professional Development, Maria Crowley, who is managing the slideshow, and we're both available for questions throughout. We are using the GoToWebinar platform, and you will receive, we're using the GoToWebinar platform for this webinar, and they do provide online and phone-in support if you have any challenges. Handouts of today's presentation are available for download. Check your attendee control panel for those, and please submit your questions in the questions pane on your control panel, and we will address them with our speaker at the end of the presentation. If we run out of time, the presenter will respond to your questions via email. General certificates of attendance are available for today's event free of charge, and at the end of the live webinar, you will receive an email with a link to the evaluation. The webinar will also be archived for later access on our website under Trainings on Demand. For viewers of the recording, please go to Trainings on Demand to find information on how to obtain your certificate. So today I'd like to talk to you about our presentation, and I was remiss at going over a little background about our organization at the outset. So for those of you who have not attended one of our webinars in the past, NASHIA, the National Association of State Head Injury Administrators, is a national nonprofit trade association, a membership-based organization, and our mission is to support state governments and states to build out capacity and infrastructure for people living with brain injuries and their families. We do this through trainings and webinars like this one, direct technical assistance, and public policy as well. We are so pleased to be partnering with Dr. Carolyn Lemsky for this webinar, but also to talk about our partnership that we've been embarking upon together over the last year, working to develop resources with Dr. Carolyn Lemsky's leadership that she's going to talk to you about today that are really focused on providers of behavioral health and individuals with behavioral health and brain injury. So I'm going to read Dr. Lemsky's bio quickly to you and toss it over to her to begin our presentation today. Dr. Carolyn Lemsky is the Clinical Director at Community Head Injury Resource Services of Toronto, and also the Director of the Substance Use and Brain Injury Bridging Project, a research and knowledge transfer initiative funded by the Ontario Neurotrauma Foundation. SUBI training and clinical materials have been used internationally to prepare addictions and mental health workers to accommodate the needs of people living with acquired brain injury. She has provided training and consultation across the US and Canada. I can say firsthand that Dr. Lemsky is truly a leader in the space. I've personally learned so much from her, and our organization has benefited so greatly from this partnership, and really excited to hear your presentation today. So thank you so much, Carolyn, for joining us.
Thank you, Rebecca. It's a great pleasure to be here, and I want to first start out by saying thank you to everybody who's attended. It is a nice big group, and I am really grateful that folks have an interest in this topic. Grateful and maybe a little bit humbled. We're really hoping that the resources that we pulled together will prove useful to you in your clinical practice, whether you're a provider working in mental health and addictions who is trying to help folks who are living with the effects of acquired brain injury, or a brain injury provider who is looking for materials that will be helpful in partnering with addictions providers. So today I'm going to be talking about the materials, but I'd like to start out with a disclosure that I am a paid consultant to the project on the toolkit, and both myself and my partner from the Center for Addiction and Mental Health, Tim Godden, were paid consultants on the workbook, the second edition of the workbook that I'll also be introducing. And again, I want to thank you, thank the team at NASHIA for providing all of their help and support. Judy Detmer helped us to shepherd through the toolkit. Maria Crowley helped with visual design and also helped us shepherd through the workbook. And we had lots of help from the Mountain Plains folks and editorial help on the toolkit from Patricia Stellan and Thomasine Heyekamp, who were really helpful in smoothing out the rough spots there. And of course, our funders from SAMHSA and the Mountain Plains and Mid-America Addictions Technology Transfer Centers. So I'm going to be doing my best to introduce the toolkit, and you should have a link to that as a part of your handouts. And the toolkit is an update of materials. I'll be talking about that were developed and originally released in 2006. And our client workbook. And what I'm going to, I also want to call your attention to the tip card. And the tip card provides a great summary. It's in your handouts as well. It provides a great summary of some of the information that's contained in the toolkit. You can see that that it's providing some basic information about brain injury, common symptoms, and the intersection between substance use and behavior, as well as a brief summary of some pointers of what to do. So those are the big materials that we're going to be talking about today. And I thought I would start out, partly because I really want to acknowledge the origins of these materials with a little bit of an overview of the history of the Substance Use and Brain Injury Bridging Project and how the many contributors to this information over the years have resulted in the product that we're going to be talking about mostly today, which is the toolkit for substance use providers and the second edition of our client workbook. So as you heard in the introduction, I'm actually up in Toronto, and I'm the clinical director at Community Head Injury Resource Services of Toronto. Now, my origins are, of course, in the States, and I moved up here having worked in tertiary care settings in the States. And if you work in rehabilitation, you kind of know that, and way back when I was doing it 20 years ago, you would spend your several weeks with a client after their brain injury, and the role of the neuropsychologist was to provide an assessment, help folks to adjust to that new situation, and then they would move on. And you really didn't know what the challenges were in a very detailed way in those months and years and decades post-injury. When I moved up to Canada, the healthcare system is quite different up here, and I moved into a community-based setting. And it was then, beginning in 2008, that I started to realize, wow, there were some big gaps in services and, of course, my ability to provide supports. And one of the big things was helping folks with serious mental health problems, and in particular, substance use disorders. And so I reached back into my professional toolkit and asked John Corrigan from the Ohio Valley Center for Addictions and Mental Health, and you're going to be hearing about his ongoing support to these projects today. Later, Dr. Corrigan, we invited Dr. Corrigan up to Toronto to give us a workshop so that we could start to provide some better services for folks who are living with both substance use and acquired brain injury. And I was lucky to have a group of folks that were really like-minded up in here in Toronto to be very willing and ready to receive this information. Now, the Ohio Valley Center for Brain Injury Prevention and Rehabilitation continues to be a leader in the area of substance use and brain injury under the leadership of Dr. Corrigan and also Ginny Bogner, who've done loads of great research in that space. What you can see here on the slide is a screenshot from their old materials. It's hard to find these cartoon characters anymore, but the original model that was presented way back in the late 90s is still very relevant today. And the idea was that acquired brain injury providers needed to be more aware of the potential impact of substance use in the people that they were serving. So, and you can see that they're on a podium there with good, better, and best. And the models that were, the basic model that was presented was it would be really good if brain injury providers were able to screen for acquired brain injury and have the ability to provide some education about the impact of substance use after brain injury. It'd be better if they had skills in motivational interviewing and were able to do a more in-depth assessment. And best would be if in the team there was an addictions provider. And of course, we took that information to heart and developed some programming. So we developed a program partnership with the Center for Addiction and Mental Health up here in Toronto. And if you're not familiar with CAMH, it's one of the premier research and treatment facilities in mental health and addictions in Canada, and is internationally known for its contributions in research. And we were lucky enough to meet a number of clinicians along the way. Tim Godden is one, but there have been a number of others throughout. And so the materials that you're going to see were originally developed with those partnerships. We were able to get some funding from the Ministry of Health initially to develop the first set of SUBI materials, and then from there on, the Ontario Neurotrauma Foundation funded us for about 15 years to do training and education in mixed groups of providers, addictions and brain injury providers. And those experiences really informed the materials that were developed. Now, we were pretty new to the scene when we developed the first provider manual, a joint group between Community Head Injury Resource Services and CAMH. So that first provider manual is the precursor to the materials that are in the toolkit now, and the same for the version of the workbook. Now, those were originally released in 2006, and in the 15 years since then, we've been, kind of doing the dog and pony, shopping around, having a lot of opportunities to do workshops and talk to folks. And we wanted to, what motivated actually the updating of these materials is that in that past 15 years, we've learned so much about what's practical and reasonable. And of course, the field itself has evolved in that time. Very key to this evolution has been our partnership with the Center of Addiction and Mental Health. And I want to emphasize again that the many clinicians that we've met through the Center for Addiction and Mental Health have helped to inform this work. They acted as our mentors in helping us to be up to date in addictions practices and also provide ongoing clinical consultation to our current program. And I'm just going to give a nod out to the folks that we've learned. This is the current team and the way it looks now. But for the past 8 or 9 years, we've been providing intensive case management supports on an outreach basis to folks living with the effects of acquired brain injury. And our team has also been partnering with community-based agencies to provide better services to folks in addictions and mental health settings. And it's the interactions with this fine group of people and our addictions counselor on this team and our work in the community that's also informed some of the materials that ultimately wound up being incorporated into the toolkit and the updated workbook. Now, through all of that work, we identified some central clinical issues. And this is something that, a line that I've stolen from John Corrigan, but it really is a very effective way to describe what happens. Many clients who are living with the effects of substance use disorders have a gap between what they say they want to do and what they're actually able to deliver on. And one of the key clinical observations in a group with people who have acquired brain injury is that gap is a bit larger. And what that actually is related to are the changes in self-management and how the brain structures have been affected by the acquired brain injury, which seem to amplify that impact. So the clients who are living with substance use and brain injury have an even more impaired ability to respond to reward and punishment, to recognize cause-effect relationships, to delay gratification, to make a long-term plan, and along the way, do things that may result in kind of short-term pain, either in terms of resisting short-term gratification or actually enduring cravings and some discomfort. We also know that our folks living with acquired brain injury were having varied to a significant degree in how aware they were of what the effects of the acquired brain injury were in their lives, how much it affected their memory and their problem-solving abilities in particular, but also how much it affected their ability to manage their own emotional state and manage their behavior. So those were central clinical issues that we identified that are present in many mental health and addictions populations, but seem to be really well amplified in folks who are living with the impacts of acquired brain injury. On the positive side, we also learned that support in the environment has tremendous benefit from these folks. And a lot of traditional service systems aren't designed to provide supportive environments. They're more designed to help an individual to exercise their own self-management. And of course, when those structures in the brain are deteriorated, it's a harder task for our folks living with acquired brain injury. So over the years, we've kind of come to understand what enables self-management and what limits self-management. And that has helped us to make more practical and effective care plans. Now, over the years in our partnerships and in our clinical research and our own education, we've come to some central evidence-based practices that you will see reflected in the toolkit. And these include motivational interviewing, harm reduction, and I'm going to underline and emphasize behavioral approaches. One approach that you may or may not be familiar with is the community reinforcement approach that's introduced in the toolkit. And essentially, the idea is helping the individual create an environment where non-using behaviors that are not associated with substance use, are actively reinforced or supported by the environment. And use behaviors are not inadvertently reinforced, and natural consequences are allowed to occur. Another really important technology that's often underused in many addiction settings are the use of incentives. Incentives that might include, say, reinforcement for a clean urine, or a attendance token for attendance. And we know from research that people with acquired brain injury do respond to immediate reinforcement. What that does is it helps to kind of make up for the difficulties they may have in delaying gratification. And so the increased use of incentives in programs where there might be a high number of people who are living with neurocognitive impairment does seem to be a good and evidence-based approach. And in fact, programs that look at opioid use disorders and stimulant use disorders often employ these strategies, but it's something to be emphasized. We also, in the materials, emphasize what we've learned about case management and case management models. And very importantly, last but not least, how to provide cognitive compensation, how to support people's cognition in the course of addictions care so that they're benefiting more from the interventions that are being provided. The program model itself has some key elements, and these are reviewed in the toolkit. Screening for acquired brain injury, recognizing cognitive and functional impairments, how to recognize them, and then support and compensation for those cognitive and functional impairments, the use of behavioral supports, and then the increased need to have close partnerships with community providers. And we're calling that assertive case management. Now, in our case, we know that very often clients don't have access to a medical approach to their addiction. So a part of our case management strategy is to ensure that addictions medicine consultation occurs. We share care with structured addiction programs. Our outreach program, as it has evolved, is often taking folks who are street involved or have very complex histories, working with them over a period of years to get ready to participate in more structured and intensive rehabilitation programs designed for people with substance use disorders, and then supporting them through those programs. And so we really need to have, in order for that continuum to work, very close relationships with community-based providers. Having materials like the toolkit helps us to do that, because we can introduce our clients using some structured information and start the conversation in a meaningful way. Our intensive case management also includes very close relationships with housing providers, shelter systems, community organizations, and all of them really need the information about brain injury and some practical strategies to address the folks, to recognize when they're seeing acquired brain injury, and to address the kinds of difficulties that they're observing in a practical way. We know that housing providers, shelters, community organizations may not have a lot of resources to put to bear. There's a wide range of service providers operating in a wide range of conditions. And so we wanted the toolkit to be the kind of material that is accessible and also practical, so that the implementation of the strategies doesn't require a lot of time or extra resource. Now, we know that for integrated programs, there's going to be certain essential features. So if you're providing services to folks in an outreach fashion and you do have the resources to do that, you're going to need a longer period of intervention. And we talk about a model that is extensive rather than intensive. That is to say that in traditional settings, we tend to front load. So a person will go to an intensive rehabilitation program, and then we're going to wean supports thereafter. The idea being that they need the most intensive support in the beginning. And many addictions programs operate in the same fashion. With many of our clients who have very complex histories and have been using substances over a period of years, the reverse is true. It makes more sense to gradually fade in resources and supports and have a focus on environmental supports, what the clinician is doing when awareness or insight into the issues is relatively low and commitment is relatively low. If we're going to be doing this work on a more intensive basis, you're going to need to have a smaller caseload and more experienced workers doing the work. And the teams will need to operate in a flexible transdisciplinary fashion. That is to say that each of the professionals on the team is going to have to be giving away their expertise. And each individual is going to have to know something about substance use, something about brain injury, and all of us are going to have to understand how community-based resources interact. So those are some features of the program that we've developed that we thought it was very important to communicate in the toolkit. Now, I'm not going to make a huge meal out of talking through the case management model. It is represented in the toolkit. But this, again, the central idea is that treatment is phased according to an individual's awareness of their disability and also their commitment to making a change. And the phases start out with engagement, which may last quite a long time. And so if it's going to last a long time, you really can't have very intensive resources. So for example, when we're beginning with our clients, we may be seeing them once or twice a week, very briefly, to touch base, to help them to have a face that they recognize, to develop trust in the program before we put in more resources. The persuasion, and I'm not in love with the name of that, but the nature of that phase is to help a person to picture their own goals, to develop a commitment to making a specific plan of action. Once that commitment is expressed, they may go into active treatment. Active treatment may be more counseling or intervention with our team, or it may be referral to a more structured addictions program, and then working with them to maintain the gains that they've made. And this is a busy slide. I think it's expressed better in the toolkit. But the central idea here is that the nature of the intervention is based on how much commitment a client is demonstrating for care and what their capacity is for self-management. So in the toolkit, you'll notice that there's a good description of insight and awareness and how to understand where a person's insight and awareness is. And the central idea there is that when a person has limited awareness and limited commitment, more of the behavior change is going to be occurring from the providers or the environment. And that's where the locus of the intervention is going to be. And as an individual gains awareness and commitment, then we're going to be looking for the behavior change to be occurring more independently and motivated by the client. It's a very important feature of the model because many of the clients that we're working with present in a kind of a chaotic fashion. And we know that the front line really needs an understanding of how to sort through the chaos that's occurring and figure out what will be the most productive set of goals to be working on. So the way that it's represented to our clients, and we do teach them about this, is, hey, the first thing we're going to do is just get to know you and figure out how to work together. How do we meet? How do we, what are the ground rules for meeting? So what are the norms that we're going to ask for? Next, we're going to help you envision your future and figure out where you want to take these things. And depending on what your goals are, we're going to help you prepare to make that change, gather your resources, take the action, and then maintain the gains. And then, of course, the mirror side of this is the model for the facilitator, the interventor, who's going to be able to understand where their focus should be in terms of their intervention and their interactions with the client. So building alliance, we'll talk, it includes setting boundaries and building routines, but it also involves creating an emotionally safe environment, enhancing motivation for change, some motivational interviewing counseling, preparation, which may be some more of that intensive case management, action may be supporting them through a treatment program, and then relapse prevention. So finally, here's a look at the toolkit itself. On the right, you can see there the table of contents. And the first section is just some brain basics, a little bit of neuroanatomy, and how the reward system works, how to screen for brain injury, and recognizing and accommodating cognitive impact of TBI, some of the recommendations for service delivery, and we've talked about the foundations of those. And then a nice beefy section of resources and references that you can use to further explore these areas. So here's just a screenshot from one of the from the earlier section of brain injury basics, where we're talking about the fingerprint of TBI and how there's a differential impact on the brain of most brain injuries that seems to affect the frontal, subcortical, and temporal structures. And of course, those are structures that are primarily involved in emotional self-management. So the reader is kind of given an overview of the fingerprint or the telltale signs of acquired brain injury and how that might impact behavior. We also kind of explore briefly some of the other sources of cognitive difficulty that can occur in our complex patients. And these do include the cognitive impacts of the substance use itself. Now here you can see that the information, there is text, but it's not that text heavy. Most of the information is provided in tabular format so that you can kind of look up the information you need and get a kind of an overview of what's most important. When we talk about screening and program implementation, there's an attempt to build in some understanding of the population and the challenges, the multiple challenges that that population is experiencing. We know that it can be difficult in rehabilitation programs to figure out when screening should occur, when should we start talking about substance use. And we also know that our understanding of substance use in an individual client is going to evolve over time as the individual feels more comfortable in disclosing what their use is, or becomes more aware, actually, of the cause and effect of their behaviors. And so those issues are addressed. We talk about stigma and how having an additional diagnosis of brain injury may feel stigmatizing and how to mitigate that. Trauma-informed care, because many of our clients may have sustained their traumatic brain injury under traumatic circumstances, such as intimate partner violence. The methods of screening, and then how to interpret the results of screening. This is a screenshot from the section on recognizing and helping to accommodate for cognitive impairment. In this section, a very simple model of cognition is presented with attention forming the basis of that. You have to be alert and attentive for the other cognitive processes to occur. And we talk about attention, processing of information, remembering information, and executive functioning and communication. Now, again, you can notice that within the materials themselves, there's an introduction. So in this case, problems with processing information, what that is, and then tables that help you to get examples of what that might look like in a clinical setting, and some ideas about what you might do to help a person to compensate if you start to recognize these cognitive impairments. As I mentioned earlier, self-awareness is an important aspect of figuring out how to help a person to move forward. Self-awareness is a central feature of an individual's presentation that helps us to choose how much environmental support is going to be required and how to approach helping them to move towards a more active change. And so the section on self-awareness helps to define what it is and where it comes from, and then also to recognize the different levels of self-awareness, the fact that self-awareness will tend to wax and wane and be particular to the particular cognitive function or behavior. So a person might be very aware, for example, of their problems with mobility, but less aware of their problems with problem solving. And we talk about how stages of awareness can kind of map onto readiness for change, and then based on what you're observing in your client, what your central tasks in treatment might be. And again, offered in tabular format so that a person can kind of get an overview of the information and access easily what it is that they're looking for. Each section has a summary of information that hopefully kind of ties things together and helps people to think about things in a functional fashion. So on the left, you can see the graphic that clients are likely to need some support understanding the impact of their brain injury and their substance use. They may need help to remember what to do and when to do it, how to make decisions, problem solve. They may need help with initiation itself, and then keeping track of what's actually occurred. And again, you can see a table of key considerations in program development. For example, longer term interventions, coordinating with community partners, and then provisions for elevated risk of impulsivity. An important feature of this is sort of a broad overview of what can be kind of a really complicated and daunting exercise, which is recognizing and helping a person to compensate for functional impairment. And so an effort was made to describe these things in the context of what might be observed in a typical mental health or addictions clinical setting. So for example, you might observe missing appointments. Well, what could cause a person to miss an appointment? Maybe they forgot, maybe they got distracted along the way. And then different kinds of cognitive compensation strategies that the clinician might decide they want to implement to help with that problem of missing appointments. So they could offer some sort of cue, they could assist with planning, they could provide a direct support, such as providing a case manager to say pick them up and bring them to the appointment, or they can provide behavioral interventions such as an incentive. And so the hope is that functional compensation approached in this way will help addictions and mental health providers apply it to the setting that they're most familiar with. And again, here is a little bit of a screenshot of one of the tables that provides this type of explanation. The final section includes recommendations for service delivery. This is a little bit more text heavy and talks about adaptations for different kinds of services, including outreach, how you might want to look at intake in order to make it reduce the barriers to access to care, some important aspects of community linkages, some modifications that are helpful when you're doing motivational interviewing with people who have acquired brain injury, a more in-depth introduction to community reinforcement and family approach and how to get more information and training about that approach, and then some ideas about making specialized referrals. Finally, the toolkit ends with an attempt to provide a very broad, very general kind of treatment plan template. The notion being that any different setting would have to modify this to suit their needs. And at the top portion, there's observations that are made that might be related to the different areas of cognitive function that they might be observing. And then some ideas about different goal areas for the different phases of care. So if we're engaging with someone, the goal might be attendance and participation. And then having a chance to try to sit back and say, well, based on what they're presenting with, how do we support them with attendance and participation? Attending while they're in the session and comprehending what's happening when they're in the session, and so forth. So again, the overall purpose of this is just to encourage goal setting that's specifically related to cognitive compensation in these treatment settings. And so moving on now to the other companion to this, which is actually referenced in the toolkit, is the client workbook. Now, the client workbook was originally developed way back when in 2006 by having our brain injury workers going through the inpatient and outpatient programs at the Center for Addiction and Mental Health, taking the materials that they were presenting, organizing them, and then making them more accessible to individuals who have neurocognitive impairment. Now, this current update of those materials retains a lot of those same kinds of activities, but in the 20 years that's happened, or the 15 years that's happened since it was originally developed, motivational interviewing has evolved. You know, things like the decisional balance are now approached very differently. Our understanding of how to encourage change talk and what the impact is of change talk on actual changes in behavior has changed a bit. So the current workbook is actually informed by those developments. It's now more overtly an MI adapted approach. We've also had the opportunity to have the old workbook actually reviewed by Indigenous services out here in Canada and by a consultant, and they've provided some information about how to make our workbook more accessible to folks in the Indigenous community. We've had more experience with marginalized communities, so there's more inclusive language. There is some reading, but it's at a 5th grade level, and the idea is, or just above a 5th grade level, I guess. And the idea is that most of our clients can manage that reading level, although if somebody's having more difficulty than that, then these materials would be read through with a counselor. Now that counselor wouldn't necessarily have to know a lot about it and could discover these things with the client together. So that makes it friendly for a brain injury setting. All of the original and the current update have exercises that encourage self-reflection. And it's sort of a sneaky way to be building discrepancy and actually fishing for change talk. So the new sections in the workbook include, is my substance use something to worry about? And that's a series of exercises to help a person reflect on whether or not there's some changes that they might like to make in their substance use. Tackling their substance use, so some specific strategies, for example, managing urges or cravings, how to rid your environment of stimuli that are related to substance use. Coping strategies for life, and these might include assertiveness, skills for or mindfulness, filling leisure time more effectively, skills for maintaining health and relationships, and that might include actually assertiveness and looking at boundaries in relationships. And then an attempt to get people to kind of pull it all together so that they're working on one or two coherent goals as they move through this process. This workbook has been sort of field tested in our own program and in a couple of other places as well, with clients working with acquired brain injury and with clinicians. And so far we've had overwhelmingly positive feedback about the inclusive language and the updated kind of look and feel of it. And one thing that I will note is that having a physical copy of the workbook for our clients has proven to be something that's really important. We're doing a lot of our work now, given COVID, virtually, and having a copy of the workbook laying in a place where the client can see that is a helpful way to help remind clients of the messages that were delivered through the online sessions. And that's whether or not they actually even open up the book. They're telling us that just having it there has reminded them of the warmth and support that they received in group. And they have a positive association with the workbook because it's written in such a fashion that that we're talking about an individual's strengths and their desires, and the language is inclusive and supportive. And we know that these are elements that are most likely to lead to actual change in the future. All of, just as in the original, all of the chapters of the workbook, they're fairly short. They may contain a brief narrative of some information. Most of them include what we used to call self-assessment, but we're now calling a check-in. And again, that's an opportunity to sort of have a conversation with your counselor about to sort of fish for some change talk. Many of our clients would have a hard time without some structure actually thinking back on their experiences and being able to understand cause-effect relationships. So having some stimulus on the page and having something between you and your client to talk about is very helpful in facilitating that discussion. It also helps to keep people focused because there's a visual focus, and then it serves as a memory tool because folks will have something to take away from them with them. Each plan, each chapter also, or most of the chapters include a plan. Now that you've thought about this, what are you going to do? Here's an example about coping with cravings. And again, there's a clearly stated goal. There's a little snippet of some information, maybe some tips, and then a check-in to stop and think about the cravings. And at the end, you can see that there's a plan. And then this plan might include creating a coping card. So where can you get these amazing resources? Well, you have them in your in the link to this webinar. Here are the URLs to get into those spaces. The Substance Use and Brain Injury Bridging Project, www.subi.ca, is the reference that's in the toolkit for downloading the workbook, that hasn't been posted yet. It will be posted on that website soon. What you'll see there now, if you were to go today, is the older version of the workbook. But in the next week or so, we'll have the new one up. But in the meantime, you can get it at the second URL, which is Squarespace, that's hosted by NASHIA. So I think, the other thing, and it figures that you really won't be able to see it. You can't see it very well on this slide. It was projecting better before. I'd like to invite everybody who's attended today, if you haven't already done so, to subscribe to the listserv associated with the Substance Use and Brain Injury Bridging Project. We're hoping to develop a community of practice where folks can ask about resources and connect with one another. We promise not to spam you with loads of posts, but the way to get involved in that is to send an email to SUBI, S-U-B-I, at info2.camh, that's C-A-M-H.net. And if you write subscribe in the subject line, we will subscribe you to that listserv. We may be through the listserv asking for feedback on the materials if you've used them, and it's also a place where you can just sort of put out a blast to interested clinicians if you have a question. And then we're going to also ask you to register at www.subi.ca. Right now, that's still serving as the backup for our listserv. So I would invite you to do that also. And I think, how much time do we have? That's the end of my formal remarks. I think we've got about 10 minutes or a little more left. And Marie, I think you were going to go back to the other slide deck, right?
Right. And hopefully people can see maybe a little more clearly that listserv address. Can you see that, Carolyn?
Thank you. Yes, I can now.
Okay. There are some questions that have been posed. I've been trying to answer some of those as we go. So I'll just run through some of these with you, Carolyn.
Okay.
And I know some of the answers to these lie within the materials that you have at your disposal, but always good to talk through some of these. Do you find that individuals with traumatic brain injury use substances often?
Yes. In our experience, like the research tells us that about 20% of people will develop a new issue with substance use disorders after acquired brain injury. It's kind of hard to pinpoint exactly where that number comes from, but that's sort of the number that we see quoted quite a bit. And certainly that bears out in my clinical experience. We also know that folks who had a problem with substance use prior to their injury, particularly if their injury was moderate or mild, are likely to return to previous patterns of substance use. There's exceptions to that rule. But what that means is that, and this is what we observe in our practice, that probably between 20 and 25% of the folks that we're working with are having some difficulty with their substance use. Now, that doesn't mean that necessarily everybody has a severe substance use disorder, but we do know that problems with substance use can occur at kind of a lower threshold after acquired brain injury. For example, we have folks who may go out for a few drinks with balance issues many years after their injury and find that even after a drink or two, they are more intoxicated and they are falling. And so those risks their risk with even moderate substance use is significantly increased. But it's an unfortunate fact that a lot of our folks have less access to the things that they would like to do to improve their lives post-injury. Some folks are no longer working. Some folks are having difficulties engaging socially. And unfortunately, those are circumstances where substance use can begin to feel like a more appealing option. So I guess that's the long answer to, yeah, we see that there's a really strong intersection.
Mm-hmm. Thank you. Can you say more about the negative impacts of screening?
We know that a lot of our clients come to their circumstances, particularly in the more complex folks that we're working, sometimes have had significant traumas along the way. And they may not have had great interactions with providers or in school systems where having a disability came with some shame or some humiliation. So some of our clients have a really negative association, not all, with having intellectual disability or cognitive disability, or just from their own experiences observing others experiencing those outcomes. And so when it comes time to screen, we sometimes get folks who feel like, oh gosh, now you're going to give me another label, another reason why I can't go and do the things that I had thought I wanted to do. And so be careful to couch the screening as a way of helping them to understand themselves and their strengths, and as well as their difficulties, so that they can take best advantage of whatever resources at hand becomes really essential. So just jumping in and saying, hey, I'm just wondering if you had a brain injury can be a little jarring to some folks. I'm going to ask you a lot about your medical history now. We find that sometimes folks who've had a jolt to the head have difficulties that we can help to manage if we know about them. Are you okay if we have a discussion about your history? Is often a better way of introducing screening.
Gotcha. An interesting question about these tools appear to be best utilized in longer term settings. As someone who works in a short-term transitional case management setting, how can I best implement what I'm learning here?
Well, actually recognizing, so, reading through the materials and getting tuned into, wow, this person seems unmotivated, and having an awareness of what might be causing me to picture him that way. Is it that he seems to be losing his attention? Is it seems to be that he doesn't remember or follow through with things I say? And then tuning into what the alternative explanations are and assessing for the presence of an acquired brain injury, understanding it, and then in your interactions in that short-term setting, providing those accommodations. It'll also give you a sense, if you were to screen and unearth a history of moderate to severe brain injury, there may be resources in the long term that might be beneficial to your client that you could provide a referral for. So so the short answer there is learning to recognize and provide those immediate compensations for a person's neurocognitive impairment, and then better understanding their history so that you can help them to transition to the most needed services. So I think I would key in on screening for brain injury, recognizing and accommodating cognitive impairment in the immediate present.
Okay, great, thank you. Is this just TBI, or can we look at drug-induced mental disorders? Would this be considered TBI with long-term drug use?
I'm glad that you asked that question. We know that the same cognitive compensation strategies would be useful in both settings, which is why we included some of the material related to substance use related brain injuries in the materials. So the answer is absolutely. There's some newer data out that suggests that when you help people to address their cognitive impairment in the context of an addictions program, whether or not you've screened positive for brain injury. You know, folks coming in will say, yes, I'm having trouble with memory and concentration, focusing specifically on that and providing some information about improving executive functioning and memory and organization actually improves their satisfaction with care, reduces dropouts, and improves outcomes. And so absolutely, there's a lot of applicability here. And of course, you know, with NASHIA and my own background, our interest, we come to this with an interest specifically with traumatic brain injury. But as you'd see in the materials, some of the same brain functions are involved and some of the same functional outcomes occur. So definitely there's applicability.
Great. I'm glad you touched on the attention issues, because one of the questions in here is about someone who cannot stay on topic during counseling sessions. So great point. What tools or resources can mental health counselors use to distinguish symptoms of mental illness and symptoms associated with brain injury? What would be helpful for clinicians to make an accurate diagnosis due to the overlap of symptoms? That's a long question.
Yeah, well, that's a $64,000 question. That comes up in clinical circles. It comes up a lot in medical legal circles. And the answer is that there really is no litmus test. You have one organ that's been affected, your brain, by both mental health, and we know that there's a lot of neurobiological substrates of mental health disorders, and brain injury, right? So one organ. So it's not always possible to, with 100% accuracy, pinpoint which went to which. What we do know, though, is that regardless of the cause of inattention or difficulties with impulsivity or repetitive thought processes, that similar interventions, particularly behavioral interventions, are helpful. So, I mean, PTSD is one good example. We know that folks with PTSD have problems with executive functioning, they have problems with attention. We also know that when we look at their brains, even in the absence of brain injuries, sometimes there's little tiny lesions that are in areas of the brain that connect the frontal lobes to the emotional machinery. Well, that makes sense because that's what's been affected by the traumatic event. We know that regardless of whether PTSD, we know that PTSD is worse when there's a history of mild traumatic brain injury and can be more complex to address. But we also know that that same set of clinical strategies is helpful. And it's even more helpful if you're presenting it in a fashion that actually accommodates for the cognitive impairment. So the broad answer to that is focus on what you're seeing and the function that's impaired and the functional outcomes, provide cognitive compensation, and worry less about, because we may never know, less about the actual etiology of the problem and more about the outcome.
Awesome. There are so many more questions, and I wish we had more time to answer some of these questions. I think maybe, Carolyn, if you're okay with this, we can just send those to you and then share the answers for those that have attended, if that's okay with you.
Yes, in fact, in what might be a really nice kickoff to our community practice is feel free to pose those questions to the community practice and start a conversation about your concerns. And so I'd really like to invite people to put their questions, post their questions up on the SUBI at CAMH2. I don't want to say it wrong.
Yep.
Post them to that listserv.
Awesome. Thank you.
Yes, thank you so much, Carolyn. I think that was a really wonderful overview of 3 new resources, 2 in particular, plus the tip card that we now have available to the community for use. And as Carolyn mentioned, the tools, the SUBI manual is available on her website and also included in the chat. They're also, all 3 resources are included on our website as well at NASHIA.org. And I want to take a minute and thank SAMHSA's Mountain Plains and Mid-America ATTCs for supporting the work. A lot of this work would not have happened if not for the support of the ATTC, which I know the link was shared. So thank you to Pat and team that saw the importance of funding these resources. If you're interested in some additional resources, NASHIA is here to help support you. We have a training that we've partnered with Dr. John Corrigan on to provide a very high-level understanding of brain injury to the behavioral health community, and oftentimes we use this training to help bridge those partnerships between the brain injury and the behavioral health communities and state. So please let us know if you're interested in bringing that training to your state. We also have a new training module coming soon, that a 3-part training series that will help train folks that are master's level clinicians on how to conduct neuropsych screening. We know this is a real need in our community, and we're excited to be able to offer those trainings in the near future. We're hoping to unveil that in the next month, so stay tuned and inquire with us if you're interested in learning more about those training modules. And finally, we're also always available to help support states and their partners with technical assistance. And we partner with folks like Dr. Lemsky to bring specialized support to your state and program through various ways. So we'd love to learn more about how we can help provide some support to your either brain injury program or your behavioral health providers and programs, and make sure that people really understand how to identify that someone's living with a brain injury and how to get them the proper support that they need. And finally, we're also launching a Leading Practices Academy in July, which again, if you're interested in learning more about, please let us know. Our Leading Practices Academy is a program that is an intensive technical assistance program that brings together a state's brain injury program with other partners in the state. This LPA will be focused on behavioral health, and again, it's really focused on creating partnerships between behavioral health and brain injury programs within the state and building capacity and protocols so that there are seamless supports for people living with brain injuries and their families. We, of course, have lots more training opportunities outside of behavioral health, but related to brain injury coming soon. A grant writing workshop featuring your very own Maria Crowley and Judy Detmer will be our next workshop, and lots more podcasts and webinars coming through. So please join our listserv or ask us how if you're not sure. We'd love to continue to provide some trainings and education to you all. Thanks so much for joining us today. We really appreciate it. We hope you learned a lot, and we look forward to staying in touch. Have a great week. Thank you.